Superb. So as people get to the microphones, we have a conversation, we have a good amount of time, which is great. I just want to throw out a question to sort of all three of you. And I want to go back to the three buckets that Hammy mentioned at the beginning of reducing scripts or reducing access, increased pain management, and then expanding treatment access for substance use disorder as being, and I think a lot of the solutions have come along those three lines. And although there is work on all three, as you've demonstrated, the first and foremost one that happened was probably more about the reduction of access to opioids. And it seems to be sort of the easiest one. And that's probably the one that's, at least in this room, has had the most troublesome consequences. And recognizing from all three of you, you spoke from your organizations and even from your experience in kind of your venues as really trying to do what was evidence-based and really trying to pay attention. And yet, it doesn't always play out that way. So I would love to hear from each of you what you think have been the greatest sort of political pushbacks, or where is the opposition coming from, or where does the challenge come from? Michael, you touched on it a little bit, but the others not so much. I'm just curious if you can each say, where do you think the pushback on doing the right thing, or doing the evidence-based thing, has been?
Sure. You think I would know this? You think I know how to do these? My immediate reaction to that was around medication-assisted treatment, where and you see that at multiple levels, right? And I think I remember having some significant discussions with folks in Congress who heard from constituents and treatment providers about the role of abstinence-based. I remember getting letters from pretty renowned treatment programs in the United States about our push to have them incorporate medication-assisted treatment. I think we certainly hear that from many parents, and what's particularly concerning for me is from the recovery community itself about this divisiveness between. So I think we see that playing out at all levels, and I do think what it results in is, even though we have pretty good access in Massachusetts through public-private payers, through a Project ECHO-like model, to be able to do that, I think we still see significant people who are reticent to go on medication because of what they hear. I also should point out that we still have 12-step organizations, chiefly NA, Narcotics Anonymous, that by policy don't promote the use of medications. So folks are even hearing it in the recovery community. So I think that is probably the kind of biggest area. One of the things that I wanted to say, and this might be a little bit provocative for this room, but what the hell, I'm not a government official anymore. We're talking about the role of inaction, or the role of unintended consequence. And I think what's important for this discussion, and I've seen this not just in the opioid space, but also in my time just in public health and the political arena, that the unintended consequence of inaction, particularly around the opioid epidemic, has gotten us some of this legislative mandates that we've seen. And I will tell you, having been doing this work, I saw pushback from state medical associations about even, some modicum of education around this, or some level, and I'm not talking about the individual level, I'm largely talking about kind of on the organizational level. And I think it warrants some level of discussion and introspection on, particularly, and again, I don't want to look in the rearview mirror, but I think it's also really important for us to say, part of the reason that we're seeing some of these kind of unintended consequences around opioid use, and I'm not talking about the individual clinical level, more at the legislative level, that don't make sense. And some of that, I think, came from a significant amount of inaction and self-policing around opioid prescribing. So I just think we need to put that on the table.
Yeah, there's also just cultural differences that we see when we look at the data, like you just mentioned MAT and the realities of what geographies that probably need a substantial. When we look at the data to be able to say, okay, these are populations that are most at risk that need MATs, and I'm talking particularly down south, in comparison now to what actually has been prescribed, we just see a disconnect there. And so I don't know if that's necessarily, we don't see data necessarily say that that's a policy pushback per se, versus the social norms and the practices that are occurring with the clinicians in those particular geographies. Now, some of that could be the reality, and I think someone mentioned that earlier about primary care physicians not necessarily wanting to be certified to be able to be MAT providers and being able to deal with the responsibilities of being MAT providers. But we do see a substantial disconnect just geographically between those that have needs for access to MAT and then the amount of physicians that are willing to be certified as MAT providers.
And I think, the evidence is not always there. So, evidence on MAT, yes, and that's what, has really been promoting, at least we've been promoting and states have been promoting. But I think we heard in an earlier presentation, there isn't the evidence on what actually works for people with, substance use disorder and serious illness or chronic pain. And so I think from my perspective, some states are not sure where to go, right? But at the same time, we can't wait for years and years before there's really good evidence out there to move. So I think we're in a little bit of a conundrum, frankly, of having to take action and maybe, not knowing exactly what the right path is. And, from my perspective, I think having a more holistic approach of trying different things all at the same time is at least one way to go. So
we'll take some questions. Is there anything first from Twitter in the middle there? Okay.
Is it on? Okay, thanks very much. This question comes from Amy L. Small, and this is really for everyone on the panel. She says, question, I'm hearing acknowledgement that the CDC guidelines have caused unintended consequences in the pain community. That's putting it mildly. What are each of you going to do to advocate for massive revision or rescinding of the CDC guidelines? That's provocative.
Well, this is Trent. I can start. I'm not certain that I agree with the premise that I would actually push to rescind the CDC guidelines. I think there's opportunities, as always, with anything that you're doing, particularly as it relates to guidelines, to be able to modify or adjust where appropriate. I think this is one of the reasons why I said it's important for us to be able to understand the evidence and the opportunities to be able to enhance or improve upon what is currently existing, particularly if we have evidence to say that there's a substantial number of individuals that are uniquely situated in these particular settings, and that is a replicable model by which we're seeing that issues unfold, then we should be able to address those particular issues, particularly if we're talking about people lacking access. As I said before earlier on, for us, primarily what we've done is pretty much not have PA for those particular situations. So where we have exclusions, particularly for PA, that is not necessarily saying that we're going against CDC guidelines. We're acknowledging that there's population that still need access to the medications while still being adherent to the CDC guidelines.
I agree with everything that Trent said, and I think folks today and the panelists today presented some pretty compelling information that it's not just the CDC guideline, right? It's not the CDC guideline, it's how they get interpreted. And is that really the root cause issue here, right? So let's, I think all of us try to say, okay, how do we get at the root cause issues? And is it a lack of training on both pain management and addiction? Seems like yes. So it sounds as if, obviously I think there is always opportunity and should be opportunity for feedback, revision, modification, clarification. That stuff just should happen by course, which I agree with. But part of this, and I've learned even a lot today, is that there are probably other root cause issues that are going into the fact that people are getting cut off from, abruptly cut off from opioids, or that we're not doing a good job of simultaneously treating SUD and people with serious illness here. So it sounds to me like let's not just kind of focus on the low-hanging fruit, but really get at kind of root cause issues here. And the other thing that I'll say here, and folks have talked about this, is, from a public health perspective, and folks have mentioned it in previous presentations, like this is not just about the opioid epidemic, and we really got to get to root cause social issues here. If we're not talking about poverty, endemic racism, lack of educational and vocational opportunities for folks, if we're not talking about social isolation, we're going to be back in this room in 10 years talking about the next thing. So.
Hi, Joanne Lynn from Altarum's program to improve elder care. Trent mentioned the appearance of this epidemic as behaving like an infection. I wonder if we are underusing the conventional tools of public health why are we not doing contact tracing? Why are we not doing public information? And the moral equivalent of immunization by having contacts have opportunities, get to those root causes. I grew up in West Virginia. There are a lot of bleak opportunities in those towns in West Virginia. It seems like the leverage of seriously taking this as public health issues would also require that we deal with the weird way we deal with substance abuse data in our health record systems. So we're working with a bunch of communities trying to improve elder care. And there are a growing number of people who are elderly who are substance abuse problems as well. But the bigger issue is that you can't get at substance abuse or substance use data in aggregated data sets. So you don't have the usual ways of monitoring. So I'm just wondering if we shouldn't really seriously increase the public health kind of attitudes rather than thinking almost entirely about doctors and patients sort of one-on-one.
Joanne, I start, and that probably also ties into the previous question from the online is, I think I'd be very, very supportive, and that's where we're trying to go. So I would be very supportive trying to take CDC in that direction to add to the armament to be able to say, hey, while you've done great work with raising awareness from an epidemic standpoint and being able to share some of the data, the solutions that normally go along with the epidemic of communicable disease, we haven't necessarily tackled that from a CDC standpoint, and there's opportunities to be able to do that, particularly here. We also think if we're able to successfully do it here with opioids, there might be for the next epidemic that come along, we'll be able to do that same model as well.
Let me just add to that, because I don't think it's just on the disease side, but also on the recovery side, right? So I've often asked the question, is recovery contagious, right? So we know from tobacco studies, right, that if one person quits smoking, the probability that those in the proximity for them will quit smoking as well. And I've often thought, from a communicable disease standpoint, not just who gets infected, but who gets into recovery. And can you think about, like, looking at a network of people who are using, and does treating one person have ripple effects in those around it? The other thing I'll say, and this struck me at ONDCP, and many of you have seen, I think, the HIV cascade of care, right? So this is the percent of people who know their diagnosis, the percent that get engaged in care, the percent that get retained in care, and the percent that get to zero viral load. Right, and as you can imagine, that goes down, and you have to look at policy and programmatic interventions. I think we should be using that same model around addiction, right? So looking at our metrics around increasing diagnosis rate, engagement rate, and some measure of recovery as our marker of zero viral load.
And I would just add, I think this epidemic has multifaceted pieces to it. So, for example, recovery housing. There are community supports that need to be linked up in a way that I think is, maybe somewhat different than just a communicable disease. So it's more complex in my perspective. And I think at the state level, they've been trying to think about how to do that, how to really link all of those different pieces in order to really try to address it. Just on your data point, we've heard a lot about that, about sort of the 42 CFR Part 2, frankly, sort of the barriers to be able to share data. And, from an NJ perspective, we actually put in our recommendations to Congress to try to address that. And so we're still waiting to see where that goes. So,
hi, David Steinhorn, palliative care medical director and critical care physician at Children's National Hospital. I've actually really enjoyed this because hearing about the adult perspective and the problem in the community, taking it beyond Fox News and CNN reports on what's going on out there has been very enlightening for me, and I appreciate that. But I want to reinforce the message that Dr. Friedrichsdorf made, that 1 in 5 of our citizens is pediatric patients. And I worry that from a policy perspective, there will be trickle-down effects of adult policy influencing the pediatric community. We already have shortages because of manufacturing of morphine in the hospital, in my ICU, and for our palliative care patients. And there are a number of other things that if these policies are too restrictive for the benefit of the adult patient, are going to limit our ability to care for children as well. Since this is a public forum and a policy session, I think it's really important that you have part of the work product of this meeting be that the pediatric agenda needs to be separated out from the adult agenda, just as we separate out pediatric disease, up to 18 or 21 or whatever, and that we need to look at this slightly differently, even though there may be many parallels in both of our populations. But to lump children in with the adult problem that clearly you have and you're dealing with nationally and internationally, I think is not appropriate. And I think that it is dangerous for a society that's already created the greatest healthcare disparity, which is being a child. And so that's the message I would like to see come out in the proceedings from this, that you make note of the fact that we need to have a separate but parallel agenda that addresses the need for children for opiate prescribing for advanced diseases. Thank you.
Anything from back there? Nope. Then we'll come over here.
Hi, Dan Alford from Boston University, Boston Medical Center, general internist, addiction medicine. This is an insurance question. So maybe you can enlighten me in terms of what happened to multimodal comprehensive pain management programs, because I'm told that they went away because they weren't paid for, and that pain specialty programs do interventions because they are paid for. And they're not really evidence-based either. So why are they paid for and why isn't multimodal? And is it time to flip the decision-making away from we need robust evidence of efficacy, because that's going to take some time, and look at the risk? Because massage therapy, acupuncture, cognitive behavioral therapy are not risky. Maybe there isn't robust evidence to support all of that, but maybe we need to look more at the kind of low-risk solutions while we're gaining efficacy evidence to support that. But maybe you can just enlighten me in terms of what happened to those multimodal comprehensive programs, and is it true they went away because they weren't paid for?
Yeah, I'd have to follow up on why they necessarily went away. So the first thing is I just need to follow up on that specific issue around multimodal, because I'm not aware of that particular specific issue as to why they went away. In terms of the clinical effectiveness, if that's what I heard you just ask about in terms of low risk, that in and of itself doesn't change the barrier by which we normally are looking at the evidence review. In other words, we don't traditionally say we're going to create a different standard per se on the evidence based upon the impact that they may or may not have. Because if you can imagine, if that was the case, I can say we should cover me putting ice on your hand today, and it has no risk whether I put ice on your hand today or not. So what we normally don't do is change the standard by which the evidence is unfolding. So we never necessarily change the standard. It's only after we get into comparative effectiveness, which is meaning after they've actually achieved a certain level of evidence, do we start doing comparative effectiveness components. So those are two different stages. The first stage is whether or not you've actually proven the evidence, meaning the net health outcome. Then you can get into the second stage is, okay, given that you've proven that net health outcome, what's the comparative effectiveness of that particular therapy relative to the standard or the reference standard? So hopefully that answers the second portion. So it's not necessarily us changing it based upon whether it's low risk or high risk in and of itself. That's not an evidence review standard.
Yeah, I just would comment that, so we had a roundtable on non-opioid pain management, and what we heard at that roundtable from some folks was in places like the University of Washington, where they had built a multimodality center with lots of different elements of how to treat pain, the insurance did stop paying for that, and so that center kind of withered away. So we certainly heard that. And I think from a state perspective, like a state Medicaid perspective, I think there's a lot of interest in figuring out how do we cover these different types of treatments, but it's like for what population and what circumstances? Because at least from sort of a state oversight perspective, they would be fearful to have, fearful is maybe too strong of a word, but concerned if like everybody who wasn't maybe indicated for a particular treatment had access to it, and that would have to be paid for, because it's, you're entitled once you have that, you're Medicaid eligible. So I think there are states working with their plans on how do we cover for low back pain certain types of treatments, PT combined with massage, combined with acupuncture. That's why I showed that Ohio example. But they're going, slowly, even though the evidence isn't there, they're trying to think about where to go next. I'm
I'm Barbara Herbert. I'm an addiction medicine and intermittently pain medicine physician from the community, even though I have some academic involvement. And I have particular concerns about insurance, about employer-based insurance. The first is that even where we have evidence that things work, like physical therapy, the prior authorization requirements in many Blue Cross plans, not just Blue Cross, and many employer-based plans are onerous and difficult and complicate the lives of physicians tremendously, so that I feel like the insurers really have not stepped up where we have non-pharmacologic interventions, except by creating these very onerous prior authorizations. Leaving that aside, which is my daily aggravation, I want to say that the absence of evidence, it's kind of a different way of saying what Dan just said. The absence of evidence doesn't mean that something doesn't work. And what we've seen here is tremendous evidence of patient suffering. So I want to put out a challenge to you, Trent, and as you talk to other insurers, about how we can figure out ways to incorporate what we clearly are hearing articulated, which is suffering, that doesn't have either the pharmacologic interest in being studied, nor the lobbying interest in being studied, but actually is in the interest of keeping healthier people, that we may need novel ways of collecting evidence that are not as dependent on the sources of evidence, which traditionally have been largely pharmacologic, even when they're also government, that figuring out how to reduce suffering and how to incorporate evidence that you could use actually is likely in the interest of the insurers. And if not you, who?
Yeah. I think the who, and I'm looking at Steve over here, is PCORI. I mean, I thought that was the whole initiative and the role of PCORI is to be able to identify priorities by which we want to be able to take a patient-centered approach, to be able to stand those priorities for America based upon that patient-centered approach, be able to do the research without necessarily having to worry about the pecuniary interest that you were just alluding to that says, but for these particular dollars, that research wouldn't occur. And so now we have a vehicle by which that should be able to unfold and occur. So I believe that the vehicle for that to occur should be PCORI. I know we look at research that's coming out of PCORI to be able to see if there's opportunities to be able to take advantage of that research that's coming out of it. So unless I hear otherwise, I would imagine that that's the vehicle that should be able to be supported and move forward.
Given the magnitude of the suffering.
We're at the end of end of the time. I'm just going to take it to a close. First of all, I'd like to thank all the speakers for a really wonderful conversation and discussion. We can continue that after. We have a 15-minute break right now. Come back at 2:45. And please stay, because this is actually going to be about next steps toward a solution. And we've been articulating the problem. Let's see where we can go from here. Thank you.